Hi, everybody. Thank you so much for having us. We're really excited to be here today to talk to you about the topic of supporting communication in people with Down syndrome and Alzheimer's disease. Can we get a show of hands who attended Karen Dodd's presentation this morning? Awesome. Okay. So quite a few people. So we'll let you know that as speech pathologists, our training and experience is in helping people with communication difficulties. And at the DSRF, we're lucky to work primarily with people with Down syndrome. We see mostly children and young adults, and our experience with older adults comes from different settings. So we've consulted with people who work in the community, who specialize in this very special population, and we've researched into best practice to put together what's hopefully going to be a useful presentation for you guys and get some resources together to get you started. And we'd like to thank Karen Dodd because we took a lot from her information. So if you've seen her excellent books, she has some great guides for supporting communication. So today we're going to talk about these topics. We're going to briefly go over what is dementia and Alzheimer's disease, although many of you had an overview this morning. Then we'll talk about how Down syndrome and Alzheimer's disease are related. Next, we'll get into the most important part of our presentation, which is talking about communication and how we can support that in an individual with Down syndrome who's experiencing dementia. So I'd like to take our presentation goals are to give family members and caregivers some resources to recognize symptoms and some associated signs with the development of Alzheimer's disease, and then to give some general strategies to support communication in whatever setting you're in. Also, we'd like to share community resources for making more individualized diagnoses and for getting information. So you won't be able to go home and do everything today by yourself. Each person that you're working with or care for will have really specific and individual needs. So hopefully you'll have the resources to find people in your community who can support you more. So can we get another show of hands who here is a family member of a person with Down syndrome? Nice. And how many people are working right now? Awesome. Okay, great. So mostly people who are working with individuals with Down syndrome. And does anybody work with somebody who has Down syndrome but does not have Alzheimer's disease? Okay. Okay, great. All right. So we'll begin with discussing dementia and how it's related to Alzheimer's disease. So dementia is a clinical syndrome. So what that means is that there's a collection of certain signs and symptoms that have to be present in order for the diagnosis to be made. It's not an inevitable part of growing old for a typically developing person or a person with Down syndrome. The main feature is that there's a deterioration of memory and at least one other cognitive function, and it has to be severe enough to interfere with daily life activities, so have an effect in somebody's real life. And so for somebody with Down syndrome who might already need some support in certain areas of life, what we need to see is that there's a change or a deterioration in some of those skills. Dementia can be due to Alzheimer's disease, but also a variety of other factors. But Alzheimer's disease is the lead cause of dementia. Alzheimer's disease is a degenerative brain disease that is diagnosed by excluding other things that could be causing changes in behavior or function. So Alzheimer's disease is diagnosed when the changes are not due to other conditions that can be found. There's a gradual onset, so it comes on slowly. The changes happen over time, and it has a long-term development. So what that means is that we usually discuss stages of Alzheimer's disease. So there's an early stage, a middle stage, and a late stage. And we'll talk more about what it means for people who are experiencing this disease for different amounts of time. Okay. So since Alzheimer's disease is a diagnosis of exclusion, what we want to make sure is that if you suspect that somebody might be showing signs of dementia or showing changes in behavior or changes in their ability to function, that we are checking their health status first. So if you notice somebody that you're living with or working with is changing how they're communicating, the first thing to do would be to contact your doctor and refer to specialists. So these are some other changes that might be occurring during aging that could also be causing changes in behavior, functioning, communication. So if somebody is experiencing pain, but like the nonverbal individuals who we were just hearing about, they're not able to express that with words and the pain goes untreated, then you could see signs that look really troubling or significant changes in behavior. Hearing and vision change is absolutely expected part of aging, and if somebody is no longer able to hear and can't tell you that they can't hear as well, you might notice that they aren't communicating as often anymore. And it's not necessarily due to Alzheimer's disease, but more likely due to their hearing loss. But again, these things can also be happening all at the same time. So you want to make sure that you're ruling everything out and checking the health status. With people with developmental disabilities, such as Down syndrome, the diagnosis of dementia is sometimes delayed because there are pre-existing limitations in cognitive functioning and communication. So when these aren't going as well as they were, sometimes these changes are just attributed to the fact that, oh, they have a developmental disability. We can't expect them to be communicating as well. So the diagnosis that's important, which is that they've developed Alzheimer's disease, is delayed for that reason. On the other hand, sometimes there are changes that occur and people say, oh, well, they have Down syndrome, they must have dementia because it's much more common in that population, which also isn't necessarily true. So basically, it's a difficult diagnosis to make, and it's important not to jump to a conclusion or a diagnosis too quickly before ruling out other health issues. So when you go to see your doctor, or the person is seeing their doctor, these are some of the tests. They're listed in your notes that you want to make sure you're checking. Some of these tests can show, like, for example, the thyroid functioning can certainly affect behavior. So you want to make sure that all of those things are checked off the list and you know somebody's current health status. So this is a quote that we really liked from the Canadian guidelines. So this is best practice and considered best practice in Canada. And what they said was that the diagnosis of dementia might be missed because changes in emotion, social behavior, or motivation, they can be gradual and subtle. So just because a person has a developmental disability and they are showing certain changes, it's not just because of the fact that they have Down syndrome. All right, and another thing that we want to drive home is that pain, the communication of pain, can also cause significant changes in behavior and communication, and you want to make sure that that a change is not because somebody is experiencing pain in the moment. When we went to a conference earlier in the year discussing this topic, we heard some really scary stories, one of which is they suspected dementia, and I think somebody almost received a diagnosis of Alzheimer's disease, and then during the medical checkup they discovered that they had a severely dislocated hip. So it's a bit of a sad story, but one to keep in mind when you're caring for people. And so this also just explains that pain is often expressed unusually or differently in people with Down syndrome and communication difficulties in general. Sometimes people say that people with Down syndrome have a higher pain tolerance. So something that it would hurt you a lot and you would express that a lot might not show as clearly in these people that you're caring for. So it's up to the caregivers to monitor overall health and behavior and try to do a lot of problem solving to find out what's going on. So when somebody's experiencing pain, these are some of the things that might change. It might just be a change in mood. Also some physical signs, like somebody starts rocking, or even something as severe as banging their head might be showing that they have pain. All right. So the next step with your doctor, if you suspect or if you notice changes in somebody's behavior, is to consult with your primary care provider and also be working to establishing a baseline of functioning. And this is important in communication as well, because communications changes are one of the early hallmark signs of the development of Alzheimer's disease. So if somebody's at risk or you suspect changes are happening, you want to be taking some information to find out how the person is functioning right now, so you can look down the line and see if more changes have happened or the functioning has decreased. Some psychological testing can help with this as well. So if we were doing a communication test and trying to figure out how many words a person knows, if we do that vocabulary test and say today they know 50 words, and then we do the same test a few months later and that number has gone down, then we can use that test to demonstrate that there has been a significant decrease in functioning. When you're establishing a baseline of functioning for people that you care for, it's important to talk to the people in their life who have known them really well and for a long time that can give you a full picture of somebody's capabilities. You want to, when appropriate and when possible, have some of these skills formally assessed with a specialist like an SLP, and also try to find out as much as you can about the person's past, their preferences, their skills, and their previous level of independence as an adult. Some sources for this information could be old videos that you might have. Also, looking at old examples of work or writing can show quite a bit. So if somebody was writing, sometimes you can see over time that those skills are decreasing or their writing is getting worse, and that could be a demonstration of a change that's occurred. So here's an idea for when you're caring for somebody with a developmental disability or with Down syndrome, is to keep pretty detailed log books about some of their communication functioning or behavior overall, so that you can look back and see when some changes started occurring. The one on the left just is a note form, so you can note important things that you see or that happened during the day that might be of concern. Or that somebody did, or something that happened, so you can show when the functioning was still existing. And then on the right, somebody's made a checklist, so that you can check off things that people are still doing independently, things that somebody has accomplished. All right, I'm going to pass it over to Jill.
Okay, hi everyone. So now that Riley has clarified what Alzheimer's disease is and some features that could possibly lead us to consider that that is what we're seeing, let's explore its relationship to Down syndrome. Okay. So in this chart here, the top kind of purpley line shows percentage of individuals with Down syndrome. And then the bottom teal line is the general population. And so we want to highlight 2 points in this graph. The first one is you can see that the people with Down syndrome are more likely to develop dementia and to develop it earlier. As you can see, the line is much higher than it is for the general population. But the other thing we want to highlight is that not everyone with Down syndrome will develop dementia, which Riley said it is not inevitable. So even at our highest age point on this chart, in a person's 60s, it still is just over half of people that were showing symptoms. And again, going with the idea that Riley said, that we want to be careful to not over or underdiagnose it in these individuals. Okay, so why is Alzheimer's disease more common in individuals with Down syndrome? Karen Dodd might most likely addressed this earlier this morning. Doesn't hurt to hear it again because it's a very complex thing. And it also says a lot about our role in supporting their communication. So ongoing research is finding that there are many genes that contribute to the onset and development of Alzheimer's disease and Down syndrome. And they're finding genetic and environmental contributors. So an example of one genetic reason for an increased risk of Alzheimer's disease is the plaques. Neuritic plaques are one thing related to the changes seen in an individual's brain when symptoms of Alzheimer's occur. So of course, these plaques are evident when you inspect a person's brain after they have passed away. And that's why the diagnosis of Alzheimer's can't be made absolutely 100% definitively when the person is living. But the point here is that amyloid deposits these plaques in the brain. And the gene that produces amyloid is on the 21st chromosome. So, since people with Down syndrome have an extra 21st chromosome, the plaques can be more abundant in their brains. And so overall, people with Down syndrome have a higher risk and earlier onset, as you saw on that graph. And you can see a faster decline once symptoms begin. Okay, so our purpose of being here today is to specifically address communication. So what changes and how we can support a person through those changes. So before I move on to discuss these strategies, I want to pause to carefully define communication and why we think it's significant. So first of all, why people communicate. Well, we communicate for a lot of reasons. We've been talking all day, probably since you woke up this morning. I know I've spoken to colleagues to be social, to greet them, to be kind, to make a good impression. I've also been talking to share information with you. And so we can communicate for our very basic needs, like saying things that we want or that we don't want, even just for safety purposes, all the way up to communicating simply for that social interaction. And when we do that, we build relationships over time and maintain them. Now, when we think about how we communicate, the first thing that would usually come to mind is through verbal means. So with the sounds we make to say our words and put together our sentences. We can also communicate with our bodies to provide visual information. So that can be with our facial expressions, our body language, our hand gestures. I'll probably use a lot of those today. And also even with more advanced visual nonverbal language like sign language and writing. So that all counts. That's all ways that we share information. So here's just to illustrate the idea of facial expressions. This person is using the same word in all three examples, but with a change in the expression on her face, the meaning is altered a lot, from very positive to negative. And it's actually a special skill that we have to be able to tell the difference and pick up on that. Okay, so this is an illustration to show how all of these skills go into producing one sentence, and that it's actually quite complicated. So first of all, our little person number one needs to have their idea, so have that message that they want to share. And that has to go to a different part of their brain to actually pick the words for doing that and figure out how to put them together. So once they do that, the message has to be sent through their nerves to actually arrive at their muscles to express it, whether it is the muscles in their mouth to say the words or throughout their body to express it with those nonverbal means. So now you just have the message going out. We have our sentence. And then our little person number two, first of all, needs to be paying attention and be able to hear well enough to just take that message in on the surface. And then they have to process the sound and send it again into those right parts of their brain to remember it, add meaning to it, and fully understand what was said. So between the two of them, you also have that red part of shared context. So that's also that shared understanding between those two people in the conversation of their background knowledge about the world and about each other and where they are and what's already been said. So there's a lot going on in just this one conversation, and breakdowns can occur at any level, at any age, for any of us, but specifically for people with Down syndrome. Many of these details can be more challenging, and absolutely, as symptoms of dementia or Alzheimer's in particular show, each step of this process can get more and more difficult. And as SLPs, we can target this at any level as well. Okay. So, thinking about all of these complex skills required for us to communicate with each other, we can see how deteriorating cognitive abilities due to Alzheimer's will spill over to affect a person's language abilities. So, we'll get deeper into these changes, but thinking about cognitive skills that are affected by changes in Alzheimer's, it'll impact a person's memory, of course, but also their attention, problem-solving skills, reasoning, and abilities to initiate or inhibit things, so that whole starting and stopping. And those cognitive skills are the foundation for our language skills. So if you see changes in things like attention, being able to attend to that conversation or stay with it will be affected. To be able to process, organize, make sense of, and then remember all of that information will be affected. Even simply finding the right words that you want to use is one thing that changes quite early on in the progression of the disease. And if we think about overall being able to initiate and inhibit things, conversation management involves a lot of that, starting and stopping and either maintaining, moving on from your topic. So all of this together leads to conversations that slowly become less coherent and focused and can lose the quantity, so the amount that a person is communicating, and then also the quality of conversations that do happen. So Riley will break this down further step by step by the stages that she mentioned, but Alzheimer's disease generally affects things like this. So here's at a glance. So it's sad to acknowledge, but it is important to consider what impact these changes will have on a person. First of all, when we're talking about communication to meet basic needs, if a person is unable to express those needs, they're at risk of them going unmet. So Riley really highlighted that pain will be harder to communicate, or even things like hunger or simple preferences, which are very important for a person's daily enjoyment of their life. It can be very confusing as the conversations lose their meaning, and also, if you're not taking in the information a person is trying to share with you, then the rest of your day is set up for confusion as well. And if you can only imagine feeling confused or not having your needs met, it can be distressing, and often a way to respond to that could be to withdraw, especially from interactions. And we really feed off that in our lives. It's important to people, so that can lead to depression and changes in behavior, and overall relationships can deteriorate. And so, to reiterate, it's sad, but we want to start at this and move forward in the presentation about ways that we can support a person facing these changes to still keep up their quality of life as long as we can and as well as we can.
Thanks, Jill. All right, so we're going to show and talk about a few strategies that hopefully you can use and start using soon for supporting communication with an individual with Down syndrome and Alzheimer's disease. So when we're talking about these, there we go, about some of these strategies, we'll mention that about memory, which is the primary hallmark of dementia. And so one thing to keep in mind is that some types of memory are affected more than others. For example, procedural memory, which is how we do things, tends to be spared the longest. So what that means is that if we have a routine that we do every single day, that is something that will stay with the person for longer because it's a procedure, something like riding a bike. You do it the same way all the time, and you can probably still carry out some of those activities. As opposed to other types of memory, declarative memory, which means trying to remember, pull something like a fact out, or word finding can be lost earlier, and working memory, trying to keep a lot of information online at a time to process and kind of work with it. So keeping that in mind, we want to capitalize as much as we can on those spared functions of procedural memory and try to compensate for some of those harder things like remembering facts or keeping information online. All right, and again, we're going to talk about the stages of dementia, or the early, middle, and late stages. So the stages are not, you don't wake up one day and move from one stage to the next. They change gradually over time, and they're kind of loosely defined by severity of symptoms. And so we're going to talk about communication at each stage. So different things and different changes are expected during each stage of dementia, more or less, and we'll mostly focus on what we can do as communication partners to support somebody who is experiencing these changes. There are also some environmental modifications that you can make that are listed, but we'll focus on the communication helpers. So a big thing that we're going to try to get across is that as caregivers and the people who are supporting these individuals, that in a lot of times, cases up to us to provide some of that communication support. And so hopefully you'll find some ways that we can do that. So in the earlier stages, that's characterized mostly by the beginning of some forgetting. You'll see, in terms of language, you'll see some word finding issues. In terms of being able to kind of start and stop and manage conversation. People might talk too much or more likely too little. They might use fewer words. They might repeat themselves quite a bit. Which can look a little bit like they're becoming obsessed with a certain topic. So sometimes you hear that people are obsessive, they're compulsive, they only want to talk about one thing a lot. But that could be to do with that inability to remember what they've talked about before, or to kind of stop themselves once they've gotten onto a topic. People tend to be disoriented, which means they might be a little less aware of where they are, what day it is, that kind of a thing. You see some personality changes that go along with this, like different ways that people are responding to what's happening or interacting. Like Jillian said, because of all these changes and the fact that the world gets a little bit more confusing, people tend to withdraw a little bit more, which can look like a depressed mood. Very understandably, there's more frustration that happens when you encounter something that you no longer can do or doesn't work as well for you anymore. So overall, people require more prompting and more active support early on in the development of Alzheimer's disease. All right, so in terms of our communication helpers, so what can we do as communication partners to support people when this is happening? We can think about the language that we're using and try to simplify that. So using simple sentences or one or two words at a time can really help to clarify your meaning. So we know that people with Down syndrome tend to have a harder time processing things that they hear as opposed to things that they see. So a full sentence is a long string of auditory information that's presented that disappears as soon as it's said. So asking somebody to remember all the words that you said, keep that in order and find meaning in it is asking quite a bit. If you can keep your message to one or two words or simplify it in some way, then that will help the person with understanding what you're trying to say. In the same way, we want to use direct language. So you or I might say to each other, ooh, it's kind of hot in here, in a way to ask somebody to open a window. You really want to just say open the window because that's more direct and easier to follow. Providing choices is very important, not only because it helps somebody express their preferences, but also because it gives the person agency and is really empowering when somebody can still have choice in their life. Even if, I don't know how it works at the places where you guys work, but for us, we often have an agenda. We have some things we have to get through in the day. So even a choice as simple as asking somebody what activity they want to do first. Do you want to brush your teeth first or have a bath first? That's just a way to provide some choice and agency during the day, and can also support their communication. Instead of asking them what do you want to do, providing choices is a way where you've given them their two options and they've heard those words that they can then try to express. Using pictures is something that we'll demonstrate in a little bit. It's powerful because it builds on a typically relative strength of people with Down syndrome, which is visual processing. Also, especially for those individuals who some of you are working with who are nonverbal, pointing to pictures might be their clearest way to communicate with you. So making sure you have a strong or a sufficient system in place to give them the words or the symbols that they need to express themselves can be important. And then offering extra information or memory aids could apply at this time too, where somebody might just need a little bit more support remembering what's happening next. So we want to eliminate the idea that we're testing people all day long and making them feel tested. So you don't have to ask them, oh, where are you going next? What are you doing? But you might remind them a few extra times that, oh, it's time for dinner. We're going to dinner now. Or going to go eat. So try to say it in a few ways so that the message goes in if it's important. At the next stage, the more what we call the middle stage of dementia, we tend to see those changes that we saw in the early changes continue, but then a further loss of comprehension. So whereas somebody might have still retained the ability to understand your language more, you might see that deteriorate a little bit as well. So you want to kind of be aware through people's actions of how much they're understanding, if they're demonstrating that they've understood you. Do they still go to the kitchen when you say it's dinner time, that kind of a thing. They might demonstrate more repetitive talk, and you also will see some physical changes in terms of the speech becoming less clear. So I want to keep in mind that speech is really a physical act. It's a motor activity, and it requires a lot of fine motor skills and muscle planning to execute. So when physical changes occur, then you're likely to see speech deteriorate as well. Going along with that, you might see reduced ability to use sign language and gesture that people had before. And that's for the same physical reasons, but also because people are starting to lose some of their symbolic understanding. So in the same way, a word that I remember represents something, the same way, it's the same with the sign. So if you're losing some of that symbolic and abstract thinking, then you might lose both words and sign language, or gestures as well. All right, so people might also start to have difficulty at this stage recognizing people who were previously quite familiar, or recognizing exactly what to do with a familiar thing. So you'll see some loss in functioning, where as somebody could pick up a brush before and remember what to do with it, they might look at it as if it's a new object. So those kinds of behaviors. Definitely one thing that is concerns safety is that judgment tends to be more impaired at this stage. So safety concerns are primary. So just be aware that change is happening, and it's due to changes in the brain. Also fluctuating mood, is similarly happening. People might appear more disengaged or restless. Again, they're maybe not able to follow as much what's happening around them, so they might appear restless because they're trying to entertain themselves, since the world isn't as clear to them. And another physical change that you're likely to see is the beginning of some swallowing difficulties. So swallowing or eating safely requires a lot of not only like cognitive skills, so I'm paying attention, I'm remembering what I'm doing right now in the moment. Also there's this sensory component of, I can feel that the food is safe for me to swallow now, I've chewed it enough. So you can feel and think about it. And then also swallowing is another motor activity that requires like really good timing of the muscles. So if there's any physical deterioration, you might notice that people are having more difficulty than they were before. And the last is an increase in nonverbal behaviors that might be expressing a need that they're no longer able to communicate using language. So what communication helpers do we recommend at this time? So one thing is just to make yourself visible to a person in a really non-threatening way. Just because they saw you earlier doesn't mean that they're going to necessarily remember that you're behind them in the room. So just avoiding startling people, making your presence felt. Using names has come up as a really helpful way to make people feel comfortable. The sound of your own name tends to be a really important word for people, and can make them feel good. And also reminding them of your name, saying your own name. Simplifying your language again as much as necessary, and then using things like your gestures and facial expressions, and just basically your patient, calm demeanor. Like that picture that showed the person's facial expressions when they were saying goodbye. The same thing, we want to be paying attention to our body language and how we're carrying ourselves, because that probably gets communicated a lot stronger than the words you say. So how you say it will make a big difference at this time. And then finally, in the later stages of this disease, we tend to see, this is when we see the disappearance of even very long-term memories. So those tend to be held on for the longest because they've been there, and they're most rehearsed. So even long-term memories of childhood, things like that, will start to fade at this time. People will be minimally oriented. So that means that they won't, they'll be unable to kind of recall things like day, where they are, maybe who is around with them. So I want to be aware of that and how that disorientation might affect their reactions or responses to what's happening or how you're talking to them. Communication, especially using any language, will be difficult and probably sporadic, which means just less often. You'll see changes in swallowing because of the physical parts of the stage, and medical complications. So basically, at the later stages of Alzheimer's disease, people are usually self-care dependent. So that's a very important time for caregivers to be involved. So in terms of communication, it's good to keep talking to that person, and even though they might understand a bit less than they did before, they're still more likely to understand more than they can express. So use really concrete communication aids. So what that means is, whereas like a year or two ago, you might have been using a picture of the bath to show or to let people know that you're on your way to the bath, now you might think, so this person doesn't understand that picture anymore, what's more concrete? If I bring them a towel, will that help with kind of letting people know what's happening next? So what can you use to support what you're saying in a way that's concrete and understandable for that person? Using touch is a suggestion that we liked, is the idea of using caring, gentle touch in a way that helps to get somebody's attention and ground them and orient them. Responding in a positive way and saying goodbye. Again, generally at this stage, I think the idea was to be aware of how you're expressing yourself and interacting with the person, and it can make the world of difference. So the overall goal is, or thing that I want to emphasize, is that communication is important at all stages of a person's life, and it really is an important part of quality of life. So your role as caregivers and family members is to support functioning and participation in daily life activities, but most of all, that social and emotional experiences are really important and are often more important than the content accuracy of what somebody says. So having a positive emotional interaction is going to be more important than getting exactly the right message in. Thanks, Jill.
Okay, so continuing with that topic of ongoing communication being important, we want to engage the individual, and it's not necessarily so much depending on how much they're saying back to you. And so in keeping this in mind, there are things that we can do in two camps. First of all, compensation. So when you think of the word compensate, it's getting around the challenges as the skills decrease using strategies. So that's more so on caregivers or the people spending time with them to adapt to the person's physical and social environments. And to do this, family or other caregivers, they need education and strategies to cope. And this support should be ongoing, because what you learn and what will work through trial and error at one point in time will keep changing. And so in order for you to be present for the person and consider not burning out, which I can only imagine is hard to do, you need that ongoing support about what you can be doing as things change. The other side of things, which we don't think about quite as much for Alzheimer's, is remediation. So remediate is thinking about fixing it. And that would be working directly on a skill with the individual. And we do this for as long as we can in whatever form that we can. And that might simply be delaying changes, delaying deficits, holding on to the person's skills as long as we can. And I think in the other presentations in these couple of days, you'll hear more about medical interventions, and we'll also just briefly touch on some behavioral interventions, just to mention that they're out there, they're being researched, and they're showing promise. And the important thing when I'm saying that you can still learn is to remember that the task needs to be at the right level for the person at that time. So we want it challenging enough that they're engaged, because if it's too simple, we're not actually making steps forward. But we don't want to make it so difficult that it's frustrating and the person shuts down. We won't make progress there either. And that's really how all of us learn and function at any age. Oops, sorry about that. It would have been nice to have a visual. So looking again at compensation and remediation. So the reason we're trying to do all this, our end goal would be communication success. And that doesn't necessarily mean that the information has made it through, they remember it, and your conversation is complete. We would define communication as successful if the person feels validated and safe, they have positive emotions from it. And one example I'd like to give, which I'm curious to hear what you all think about being able to do this. I heard a story on the podcast called This American Life, and it was about a family who the wife's mother had dementia, and she was living in the home with her daughter and her daughter's husband. And the husband was an actor, so he was used to the stage and used to thinking on his feet to perform. And so what they learned at a family training day was, instead of correcting the person and making sure the facts are straight, it's more about the person feeling comfortable and positive. And so they decided to go with what they were saying and what they were thinking. And so an example was they were having breakfast in the kitchen one morning, and the woman with dementia was staring out the window, and she was quite bothered, and she said, she was talking on and on about the monkeys she could see in the yard, in the trees, and the husband just said, it's pretty early in the season for monkeys, wouldn't you say? And she just went, yeah, I think so. And then they had a really fun conversation about something that was not accurate, but he didn't correct her, and it was quite a long interaction, and as far as he was concerned, it was successful. So I know that's not realistic throughout the day, and there are times that you need to share information, but thinking about that monkey example of not always needing to correct that person. So to reach our communication success, these are the things that are involved. So first of all, the skill of the individual. So in this sense, we're referring to the person with Alzheimer's disease. And so their skill level will change often, and it involves things like their current level of speech, memory, using words, and even their personality and mood that they're coming to the table with. And then the next part of the equation is the skill of the partner, so all of us in the room today. And that involves the strategies that you have, but also your personality. So it might not be as comfortable for you to be creative and roll with those notions, whereas other people would enjoy that and feel comfortable doing it. So there's some trial and error and strategies that will work for you at certain times and not others. And then there's also a degree of what you're comfortable with and things that you are better at than others. And then finally, the key piece of the equation is the resources available to the partner. And so hopefully that's where we come in, and other experts here, especially the speakers at our conference this week. And so it's just to be able to get the support and training and access to the help that you need. So here's our first example of a quick acronym, because we will be giving you a lot of strategies. Some will be repeated, hopefully to help them stick. But if you can remember one thing, this is at least one quick word to try to keep in mind. And we liked the ideas behind it, so we put it in a handout. So it's called the Focused Program, developed by Ripich in the 90s. So we handed our package out to those who are in the room a few minutes before the presentation. If you didn't get one, they're on the table at the front, or you can grab one at the end. So this is on our side of compensation, so training the caregivers to change their style and expectations in the interaction. And it was developed for individuals with Alzheimer's disease, but we fully support that this can apply and support individuals who also have Down syndrome. So the F stands for face, so that means facing the person directly so that they know that you're there and connected. we did learn from a really helpful nurse named Karen Reese, who works in homes with individuals with developmental disabilities and, sorry, I said Catherine Reese, developmental disabilities and dementia. And she said for some people they've learned that we want to be face-to-face, but if being directly in front feels intimidating or aggressive, you can aim for more of a 45-degree angle. So you're within their line of vision, but you're not directly facing them. And as Riley mentioned, using their name can be comforting and let them know that it's them you're talking to, and a gentle touch to orient them to you is another way, along with the eye contact, to be connected and hold that interaction. The O stands for orient. So as best as we can to keep the person oriented to the topic, to use all specific labels and language. So first of all, using the names of the things and people you're referring to. So if I first told you I saw Riley today, and then as I told my story, I said she, I told her this. If your memory has deficits, by a certain point you might not remember who she is, and so to reuse that name as you go, or instead of saying I went over there, use the place or the object again, and just orienting them by repeating the key words as you go. Emphasize the most important words and keeping our sentences shorter and simpler so that as a person's understanding of the words they hear also decreases, you're meeting them at that level. The C stands for continue. So if you are continuing a topic, again, keep restating it so that they know you're doing so, and signal if you're going to move to a new topic. So really being as explicit and direct as we can be. The U is for unstick. So you will run into barriers or confusion, or the individual could get stuck trying to think of what it is they want to say. So perhaps in an earlier stage when they are still talking more to you but starting to have trouble recalling the words they want, you can get stuck, and that's not comfortable. And naturally we might feel a little panicked to do something about it. So the best thing you can do is just calmly help the person by suggesting what they're looking for or reminding them what you're talking about. And it can be in more tactful ways, like simply repeating their sentence but replacing the correct word in there, just to provide it to them and get them out of that moment. The S stands for structure. So that's how we structure our questions and things that we say. And so one structure that's really helpful is to provide choices. And Riley went over this already. Instead of saying, what do you want to do today? You can say, do you want to do this or this? And then that way they've heard the choices and they don't have to go into the depths of their knowledge to think of, well, what are my choices? How do I even say that? And also providing more so yes and no questions is one of the easiest you can answer. And so even the way that you word it, providing that choice or those yes-no words at the end of what you say, so then the word's there for them to repeat rather than recall what to use. Okay, and then for E, for exchange, it's just keep up your chatting and let them know you're interested. And so I like to look out at you and see you smiling and nodding at me, or if we were in a direct conversation, you might say, oh, wow, that's great, or really. And those are just little things to let the person know that you're following and into it. And so and for questions, we want to avoid testing. So things like, what day is it? Who just won the election? We say things more so that the person is likely to have pleasure in discussing and asking things that they're still more familiar with, like a distant memory that they would enjoy talking about, like talking about their dog growing up. And if you have asked a question, which you're allowed to do, giving little clues and scaffolds to guide the person in answering it. And then D is just direct. So again, using short, simple sentences. Okay, so this continues on with the principles, just in further detail. It's based on what's called SCEA, so Supported Conversation for Adults with Aphasia. But the principles of emphasizing the adult's competence and using the strategies that work for them to enhance their competence still stand when we introduce Alzheimer's instead of aphasia, which is just another kind of language disorder that happens more so when someone has a brain injury, like a stroke or something like a stroke is what could lead to aphasia, but again, the principles still stand for dementia. So the main ideas are threefold. So first of all, getting our message in. So things that we can do to help the person understand what you say. And so thinking back to that question at the start of the presentation about a person who's nonverbal, I think it absolutely changes the strategies that you would use and how you interact with them, even if they're nonverbal, because you're still giving information to them. And then we'll go over how to help them get the message out, so express themselves. And that still doesn't have to necessarily be with words. It could very well still just be with their facial expressions, pointing, whatever still has meaning for them. And then it's important at the end to evaluate the response. So like we said, these strategies can be trial and error for you and the person you're using them with. And you can't put so much pressure on yourself for it to turn out perfectly. But the best thing you can do is afterward, pause for a moment and just evaluate how it went, how the person seems, and maybe what to keep using or what to try differently. So let's start by how to help the person understand what you say. We've already said to help orient the person to identify yourself as well as using their name. So saying your name when you approach them. Talking about minimizing distractions, which I'll illustrate for you soon. But those distractions can be visual, so the things that the person is seeing, as well as auditory, so what the person's hearing. Again, sitting still, so we're not distracting, and sitting close enough to be engaged, but not so close that the person is uncomfortable. And just using eye contact, smiling, being relaxed and patient. The person will pick up on your vibes and even possibly assume those same vibes. And so if anything, focusing on being relaxed and patient, even if that's not how you actually are feeling at that time. Using a natural voice with your normal volume. So, if the person has a hearing impairment, we want to correct it with a device, and you might have to speak with a lower voice or a louder voice, but somehow we naturally shout more to help be more clear for a person, and that isn't helpful, and it can be something else that can irritate the person. And just speaking clearly, slowly, and gently. The idea of talking slow, giving just one piece of information at a time, one point, one question, one step in the direction, that all gives the person a chance to process it and hold on to it. And it also gives you a chance to have to repeat it if you need to, if you're only using one piece at a time. And that's the same reason you would pause frequently, to let people process. Today we're flying through this information, but ideally we should go slow and pause so that you have a chance to really put it together and make sense of what you've heard. And the words that you're using and the lengths of sentences that you're using just need to match the level that that person's understanding is at the time. And augmenting what you're saying with visuals and gestures as much as possible. So we'll show you a lot of that. Saying things again, saying things in different ways. So saying, I'm going on vacation. I'm taking a trip. one of the ways might be more helpful than the other. Or if there's some confusion, the next way of saying it could clarify. Being specific, so again, like I said, using Riley instead of she, and avoiding negatives. So if I said, no, don't close the door, it could be easier to understand if I just said, leave the door open or open the door. The person doesn't have to go through another step of understanding what that don't, that negative means. Okay, so I'll illustrate some of these. So hopefully it'll help you remember. Starting with distractions. So, which word list is easier to take in and remember? I hope it's the one on the left. And so this looks exaggerated, but perceptual difficulties can make stimuli this overwhelming. And so it can be something that's visually distracting, could even be sunlight coming out in the window and dancing off the wall in a certain way, or other people walking around behind the person you're talking to. Things that you can look past, but at certain stages could make it more challenging for the individual to focus on you. And like I said before, it can be auditory things as well. So if a light is buzzing or there's a lot of people talking in the background, that can make it more difficult. And just thinking about our body language and demeanor. This woman is relaxed and patient, and the woman on the right, she seems rushed, she's scowling, much less inviting. Okay, speed, let's see if I can play this. Here's our first clip. Too quiet. That's okay. The idea behind that is we just compared the slower speech to basically an auctioneer, and it can become a point where they're real words, but they absolutely blur together and can lose their meaning. Okay, and keeping things short and simple, or the words, again, can blur together and lose their meaning. I might be sounding like Charlie Brown's teacher by now. I hope not, but it's possible. Okay, and again, being specific. So if I said, can you pass me that? There's a lot of things I could be referring to. Can you pass me the red pen? That leaves no room for error. You might have known the context, like I was about to underline something important, but being able to remember and pick up on those nuances is probably not what the person is able to do. And the idea of using visuals, so this is just to think, imagine if you're in a foreign country looking at a foreign menu or hearing another language. Spoken word can feel like this for an individual whose language is losing its meaning. And so what a world of a difference it makes to be able to see a picture with it. And it can also be with objects. So instead of just saying, what do you want for breakfast, where the person has to know what breakfast is, think of all the things they might eat for breakfast, think of the words, and say what they've chosen. If I brought, do you want oatmeal or fruit, and showed you, I've phrased it with choices as well, and you can simply point to what you'd like. Or maybe you're not pointing, but I can see what you're looking at longer. Whatever clues you can use might show what the person prefers. And here's just objects as well. In this sense, it could be providing the person their choices with the object, or perhaps handing them the comb helps to say, it's time to brush our hair and get ready. Or like Riley said, handing them the towel, it's time for their bath. And just to think about, really briefly, the pictures that we use, because we're making such a big deal about using visuals, but we want to say don't immediately rule out the use of visuals if they're not successful right away. There could be things to adjust. So thinking about if these drawings or icons can work for a while, but they are more abstract. So there's a step more removed from what they're referring to. So moving on to actual photographs or the actual objects is closer to what you're referring to. And anyone can use these pictures. You can use programs like BoardMaker or PEX, but more so we will just Google image the item and trying to find something as close to what is meaningful to the person as possible. and thinking about the way our pictures look. So the book is quite clear, and there's not a distracting background, there's not a lot of clutter, and it's clear what you're referring to, because the picture with the woman could be, I want a blanket, or I need to take a break. So just making it as clear as possible, and even using your backgrounds and color to draw attention to the item, so there's more contrast between the black and yellow, or to add meaning, for as long as the green and red can still mean to the person like first and then, or go and stop. And so, again, as the person's processing skills and symbolic understanding changes, we can adjust what we're using to keep up with that. And thinking about how big the visuals are, if a person might need them this big because of their visual skills, or they can be this big and it's easier to carry around with you. And thinking about how much detail and complexity you have. The picture with the playground, it is a bit confusing what it's referring to if the word itself on there doesn't mean much anymore, and it's a lot to take in. Okay, and so using visuals in things like choice boards, so we want to provide choices. Instead of saying park or beach, which is quite abstract, they can see the picture of either. Or having a visual schedule, which is really comforting because you know what to expect, and the person can also refer to it at any time if they forget, because it's not going anywhere. Unlike the words that we say are fleeting and then they disappear in real time. And you can even do a visual schedule with objects. So they're showing brush hair, wash face, and brush teeth with the actual objects the person will use. And we absolutely can't say who or when those will work. But I'd be interested to hear if anyone's been successful with that. If we have time soon, we can talk about it. But it's just something to consider instead of closing the door on those options. So as opposed to something with a lot of text or detail, it can be overwhelming. Thank you. Here's Riley again.
All right, thanks, guys. So now I'm going to talk a little bit about getting that message out. So this really does overlap with a lot of what Jill was just saying about using visuals, because visuals are both to help understanding and can then also be used to help somebody express a message as well. And I also just want to add that if you're going to introduce something, or if you're using something like a picture schedule, then one thing to keep in mind is that checking that picture schedule can be part of one of those routines that you set up, making sure that somebody's used to checking their schedule regularly, because then this can be part of that procedural memory, that memory that's intact, the physical act of going, looking, and picking out your pictures. So let's keep going. So when we're thinking about getting the message out, this is really just helping somebody express an idea that they have. So you want to, if necessary, give nonverbal ways to respond. And as the communication partner, it might be our job to provide some options, or to find ways that they can respond that works for them. Some other general strategies are just talking about things that are interesting to that person. Again, that's validating, it's reaffirming, and it's fun. And also giving lots of time. So our patience is really important. Make sure you build that into your day as well, so you're not feeling rushed to get through all the things you have to get through. Jill talked a little bit about questions. Again, if we are expecting somebody to answer a question, so to express a message, what's the easiest way to do that? The bottom of the mountain shows choice questions, or yes or no questions. The response is right there. The response is easy. The answering an abstract question like how or why is a lot harder, because it involves some of those skills that tend to deteriorate faster, like reasoning. So we want to try to avoid those. Or make them, or answer them. If you ask somebody a complex question, try to help them find the answer. So when we're thinking about helping somebody express themselves for a reason like their basic needs, maybe pictures are a way to do that. If somebody's still understanding really abstract concepts like colors, or that green usually means go and red usually means stop, or thumbs up means yes, then something like this might be helpful. But you always want to use that step of evaluating whether or not it is, because we know that more concrete communication tends to last longer, and this kind of abstract idea might make sense to us, but can lose its meaning for a person. So that brings us to the next step of really evaluating a person's response. And that helps us to evaluate whether our strategies, our interventions have been meaningful and have been successful, and whether or not we're going to do the same thing again next time. So a question to ask yourself, if you're trying a strategy like using a choice board, or if your strategy is going to be saying just one message at a time, or your strategy is using gentle touch, whatever you pick to try, ask yourself, did that work? And the way you can tell the difference or tell if it worked is to think back to that communication equation where we defined communication success as when a person feels safe and validated. So check in with the person and how they're feeling. At the end of the interaction, does a person appear calm, or have they increased their agitation? So that's the number one thing to think of. And then after that, secondary is, did you both get some helpful information, but this may or may not be as important to you and the individual, depending on their stage and communication level. But most importantly, how's everybody feeling? One way to evaluate that is to really look at the person's body language. We often get interested in what somebody says. So if we said, how are you feeling? And they say good, but they don't look good, then that just might be an automatic response. If they say good, but you notice that they're showing a lot of tension or some physical agitation, that's the most important thing to look at. So check in with the person's reactions, their sounds, the sounds in their voice, and of course their behavior. And if something doesn't look all good, then it's time to go back to the drawing board. What else can you try? Can you find another strategy? What can you do? How can you change your interaction style to maybe help the person to feel better? So things that we can try are reflecting back and validating some of those emotions people are feeling. So if somebody is looking a bit sad or is crying, you might just say, oh, you're sad, that's okay. Adjusting your body position and language is great. So if you notice that you're standing over somebody, try getting at their level, even if that means sitting or kneeling down, or getting, maybe, like Jill mentioned, instead of being dead on face to face, which can be a bit intimidating, bring yourself a little to the side and see how that works. Try that gentle touch. I know we're saying some things like this a lot, but this is why the evaluating is important, because maybe touch is really agitating to the person, and you're just going to have to, just because we said that this is a possible strategy doesn't mean that we need you to definitely do it. You have to check with the person at the time and see if it works and if it helps. Also, check in with your own voice. Are you using a soft, gentle voice? One strategy that Catherine Reese talked to us a lot about for people who are experiencing memory difficulties was just using gentle redirection. So if somebody is in a situation where they're really agitated and things aren't going well, maybe they're having a problem with another person, instead of trying to figure that out and problem solve it, what happens if you take the person to another room or a neutral space or something where they feel more comfortable, like their bedroom? Is that still a problem? And the message she gave us was that often if you move to a neutral location, remove the person with memory difficulties from a challenging situation, then lots of then that feeling of being challenged goes away and people tend to feel calmer. So now, moving on, we'll mention just one or two things about some other things that you might try. So in terms of remediation or some things you can do to improve a person's communication. And we'll just talk a little bit about it because lots of times when people are in a period of life of experiencing Alzheimer's disease, they're experiencing some declines and learning is harder. But there's one strategy that we really love that can serve as a basis for a great conversation or interaction, and that's using a memory book. So memory books are basically a book that you make that's about a person's life. We like them because generally they contain pictures and some information so that you can have an interaction with somebody that's personal and about their life, but the onus isn't on them to recall facts. The facts are there and they can be discussed with the person. So this is an example that we like, and you'll notice a few things about it. There's just one or two pictures on each page, and then some really simple text. So whereas a piece of declarative memory that we're calling facts memory might be really hard. So if I ask somebody, what's your birthday? That's a challenging question for lots of people. But if we have a page like this, then all somebody has to do is point to the place where their birthday is written. And likely people are more likely to be able to recognize that that's their birthday, rather than recall it. So having something that somebody can use and recognize can help them continue in a nice conversation. We also put some examples of things you might want to think of avoiding. One is just having lots of text. So that kind of takes away from the fact that we want this memory book to be kind of a point of interaction, of conversation. So if you're sitting down with somebody and there's all this text, most likely people will sit and read that text and you lose the interaction. And also that might not be as meaningful for the person you're working with. So having too much text isn't necessarily helpful. And then again, thinking of that the sensory and perceptual difficulties, a visually busy book isn't necessarily that helpful. This book we liked, or this had a nice idea that we thought of for somebody who was really experiencing visual or perceptual difficulties, which was having tactile objects in a memory type book. So there's lots of ways you can be creative with using keepsakes as a way to share information and share a moment. All right, so we're wrapping up, we're getting to the end, and so here we just have a few ideas for you. We put together, we knew that there would be, since we're not experts in this specific population, we did put together a list of more in-depth resources, places to look for information, so that's in one of your handouts. I'll grab it. And it looks like this, so please take a closer look at that, and you'll find information about different organizations in the Lower Mainland and around Canada, and different places to find books and resources and things like that. If you're interested in finding a speech and language pathologist in your community, then this is a good place to start. It's the BC Association of Speech Pathologists, and they have a website where you can look up people who specialize in the population of developmental disabilities or the population of people who are older. Occupational therapists as well can help with helping structure the environment and certain routines, and both can help with certain things around mealtime or feeding safety. So if somebody's having feeding difficulties or eating or swallowing difficulties that you're working with, check out, you want to contact a SLP or an occupational therapist. And an excellent resource to get started is always the Alzheimer's Society of BC, because they have a great network and tons of resources and can point you in the right direction. So if you lose our resource package, call them. So tomorrow, Dr. Elizabeth Head will be discussing some ideas of ways to prevent cognitive decline in people with Down syndrome. And so we just have this one slide with just tips that are really good for all of us. So of course, regular exercise, sleep, especially considering that studies are showing that a really high percentage of people with Down syndrome will experience sleep apnea. So that certainly can affect cognitive decline over time, or cognitive skill over time. Cognitive stimulation and social stimulation kind of can go hand in hand as well. So the idea that we need lots of new experiences, we need to keep learning and in order to maximize our quality of life and have lots of things to talk about. And then, so take-home points. So if anybody asks you what you learned in our presentation today, you can maybe just remember these 3 things. And one is that Alzheimer's disease is just more likely to develop in individuals with Down syndrome, so it's important if you're working with an adult to try to establish a baseline of functioning in order to help monitor changes over time. But not everybody with Down syndrome develops Alzheimer's disease. That's a pretty common misunderstanding. So it's important to always explore and manage other possible health issues that are leading to any changes that you're seeing in an adult's behavior. Also, we as caregivers or support workers can really help and work to optimize an individual's quality of life by structuring the environment and adjusting our communication methods to be appropriate and supportive for that person.